Foramen Magnum Meningiomas are like the distal most skull-based meningioma. We started from anterior cranial fossa, middle, and foramen magnum, and it goes beyond the skull base, that is in the upper cervical spine. The foramen magnum meningiomas are not only restricted to the foramen magnum, it goes beyond foramen magnum and requires exposure of craniovertebral junction. So small tumors just ventral to the medulla or spinomedullary junctions are mostly detected incidentally because there's a lot of space around the spinomedullary junction at the CV junction level, and tumor has to become enormous in size before patient becomes symptomatic. Whereas such a small tumor placed anterior to spinomedullary junction can present with paresthesias, non-specific neck pain, and many of these patients are not investigated even for many months or years because they do not have any neurological signs. And till the tumor grows further laterally and starts compressing the brainstem or upper spinal cord, then patient develops neurological deficits. So one more thing is, like, if you detect very small tumor, just enter it to the foramen, just at the foramen magnum, and the surgical approach will be difficult because you have to go ventral to the spinal cord, and you cannot go from posterior. Even from posterolateral approach, it is difficult because it is dead ventral, and you see only the medulla or spinal cord. You don't see tumor in spite of removal of lot of bone, and with extended endoscopic to transnasal approaches, these tumors can be removed. But problem with extended endoscopic transnasal approaches is the tumor extends lateral to the occipital condyle, which most of the foramen magnum meningiomas, they extend beyond the occipital condyle laterally, and you cannot remove. So there is something called far medial approach also you can do through extended endoscopic transnasal, that you can drill the occipital condyle through the nose and can remove up to some extent, but most of the times not. So what happens, as I show, like doing simple midline suboccipital craniectomy will not expose the tumor ventral to the cord or medulla. But as the tumor increases in size, you will be able to see the tumor lateral to the spinomedular junction, even with midline suboccipital craniectomy, extending laterally, as much lateral as permissible. And but if the tumor is small, you will not be able to see the tumor without retracting the spinomedular junction, which is not advisable. And in that case, you have to do extra drilling, that is drilling the occipital condyle. Now again, there is a lot of controversy how much occipital condyle to be removed, not to be removed. So one size does not fit all. So you have to tailor the amount of occipital condyle removal depending on the site of the tumor, whether it is dead ventral or ventrolateral, and size of the tumor. Even if dead ventral tumor but enormous in size, will provide enough space, so you don't have to drill so much condyle up to the hypoglossal canal. Like classical people describe total resection of condyle till the hypoglossal canal and expose the hypoglossal canal. That is not required in most of the symptomatic tumors, because most of the symptomatic tumors would have become big enough to express themselves laterally rather than remaining only ventrally. So this is how you classify meningiomas, like dead ventral or dead dorsal or ventrolateral or dorsolateral. So besides that, in relationship to the vertebral artery, as I told you, it is not only skull-based meningioma, it is craniovertebral meningioma. So the tumor can be predominantly below the vertebral artery, it can be predominantly above the vertebral artery, or it can be straddling across the vertebral artery. So when it is straddling across the vertebral artery, at that time there are a lot of difficulties in removing tumor. It is akin to our anteroclinoid meningioma, which encircles the internal carotid artery, and you may find difficult to remove the tumor without risking the internal carotid artery. So once you enter after doing the bony decompression, there are corridors, like you will have corridors for suprasellar tumors between the optic nerves, third nerves, and IC. Similarly, there are corridors at the foramen magnum and spinomedullary junction. There is the first corridor, which is shown. It is between the 11th nerve and the vertebral artery, that is upper corridor, and second corridor is below the vertebral artery and lateral to medulla, and corridor 3 is more at cervical, it is below C2, medial to medulla and spinal cord, but lateral to the vertebral artery. And corridor 4, which is very small, which most of the time we don't use, it is lateral to the 11th nerve. This lateral to the 11th nerve, if the tumor is lateral to the 11th nerve, then it can be exposed also with midline suboccipital craniectomy. Again, there is a divided opinion about incision. Like from our own hospital, one of the unit prefers this type of incision. I prefer this type hockey type incision. The advantage for me for doing this incision, you can go in layers and it causes less bleeding because you go in the muscle planes. Like superficially you go trapezius and sternocleidomastoid to detach so that one plane is gone, then spinal capitis and other deeper muscle, then reflect the next layer. So you reflect the muscles in layer, you don't cut across the muscle. Then finally you go to suboccipital triangle comprising of 3 muscles where you will see the vertebral artery. So with this is my argument for my incision. However, people who make this type of incision also claim that they can also see all these muscle layers. But here you are more likely to cut across the muscle, whereas you are more likely to reflect muscle. Disadvantage with this, like you leave a lot of dead space because it's like a flap. So there is a potential for pseudomeningocele collection of CSF, whereas you go in between the muscles, so there is no flap. So pseudomeningocele probably is less, but we don't know. I don't have proof to support my statement. So I will show couple of cases, and the main purpose is to show these 2 videos that there are different approaches for the same tumor, and it's not the approach, it's the tumor which decides how will you do. So this is so-called far-lateral approach. As I already told, how much lateral, it's customized. It's a middle-aged lady with quadriparesis, and you can see the tumor is ventrolateral. And this suboccipital exposure, this is digastric groove, mastoid tip, and it's the foramen magnum region. This is C1 arch. This is vertebral artery. So this is a groove over the C1 arch for the vertebral artery. So dissecting the vertebral artery from the bone, so it is attached to the bone through venous plexus and soft areolar tissue. And you can see the vertebral artery. So when you see a number of veins on the lateral aspect of C1, you know vertebral artery will be below that. It is very well protected by soft tissue as well as venous plexus. So if you use monopolar coagulation to dissect, you are likely to injure the vertebral artery. So better to use sharp dissection using knife or sharp dissector. Even if you use dissector, make sure your dissector is sharp. Like over time, the dissector gets worn out and it becomes blunt, and blunt dissector will slip rather than dissect. So we'll make a small burr hole using drill and do a mini craniotomy to remove the suboccipital. It's like a suboccipital craniotomy. Medially, again, how much medial you want to go, you can go all the way up to midline depending on the size of the tumor. Like here, it is almost up to midline. Laterally, we don't do craniotomy. Laterally, we can remove the bone using rongers and drilling the master. Sometimes master drilling is required. And here you expose the sigmoid sinus, and with alternately rongers or drill, you keep on removing the muscle laterally, bone laterally to expose the sinus. And then this is the occipital condyle region. And again, occipital condyle is being drilled. It's not drilled extensively, it is just drilled. And dura is open like C shape based laterally. C or L shape, whatever you want to imagine, alphabet like. Then this is a dural opening across the foramen magnum into the upper cervical spinal canal. So this is how dura is open and tumor is visualized. You can see the tumor, the denticulate ligament is cut, and we go ventral to the tumor as much as possible. As I told you, it is not possible to go ventral or lateral to the tumor to devascularize and detach completely without some amount of decompression. So alternate decompression, detach, dissect. It goes in tandem. There are no rules that you do one thing first and second thing and third thing and so on. So I usually prefer to leave a small sliver of tumor at the attachment, because you try to detach it too early. And if there are feeders from the dura, they get avulsed and it will cause a lot of bleeding and you don't see anything. So leave a layer of tumor, remove rest of the tumor, and then to so-called complete the extent of excisions, you then detach or devascularize or even cut the dura depending on the space available. The vertebral artery can be protected with rubber sleeve when you are using pottery or any other sharp instrument, and you can mobilize the vertebral artery. Here you can see the vertebral artery is encased by the tumor, and a small layer of the tumor is left all along the vertebral artery. So there are some proponents that you cut the dura all the way to vertebral artery, and you can mobilize the vertebral artery. But in this case, anyway, dura around the vertebral artery was also infiltrated by tumors, so that would not have given me extra advantage. Here you can see small hump of the occipital condyle. So if that hump is interfering in visualization, you can go out again and drill the condyle further if required. So this is the total resection of the tumor. So now this case, again, resident felt we should do far lateral, but it's not necessary that you should do far lateral for all foramen magnum meningiomas, even if it is ventrolateral tumor. So this is again 60-year lady with classical symptoms of paresthesia. So you can see the tumor is quite ventral, lateral, but tumor is so big it is coming posterior, it is displacing the medulla, and it is coming in cerebellomedullary fissure, which you see in midline suboccipital craniotomy cerebellomedullary fissure. So tumor has come posteriorly from anterior to posterior. Though the attachment is anterior or lateral, the tumor has come posterior. So there is no need to do extensive bone drilling in this case. This tumor has itself given enough space for us to reach to its attachment. Yes, in such cases, if you don't go to attachment early, you may have more bleeding. But luckily, we did not have much bleeding in this case. And as you decompress the tumor gives space and you can reach the attachment. And slowly you cut the denticulate ligaments again, the dural attachments, and keep on decompressing and dissecting the tumor and reach the attachment progressively. So this is how it is done. So tumor will come out, like now you can see the hypoglossal nerve. So tumor is going so anterior, you can even see the hypoglossal nerve. From posterior you can see hypoglossal nerve. It is because of the tumor, not because of your extensive bone work. So sometimes tumor helps you for the surgery rather than the bone resection. So then again, superior pole of the tumor is decompressed and gradually being resected. So same principle: decompression, dissection, and detach. So you keep on repeating all these steps, and then you can deliver the tumor totally. So here you can, this tumor was quite big. It was coming from anterior to posterior, medial to lateral. So it took, though the bone work did not take much time, it was just midline suboccipital craniotomy and 7-arch resection. The tumor removal took much more time as compared to the previous case where bone work took more time, but the tumor dissection did not take because we could reach the attachment early. Now vertebral artery is visualized, and you dissect the vertebral artery and remove the tumor. So from this posterior approach also you can have panoramic view of lateral part of spinomedullary junction, even the ventral part of the spinomedullary junction, because of the tumor which has given the space. And this is how you resect the tumor totally, and it looks pretty good. So the purpose of showing this, not all foramen magnum meningiomas, even ventral or ventrolateral meningiomas require far lateral approach.